Welcome back to another episode of Diabetic with Files. Today, we're going to dive into a topic that sits at a crossroad, well, actually, the crossroad of medicine, microbiology, and mind. So, everybody knows I love alliteration, so MMM. And imagine this, a patient with a diabetic foot ulcer already has an infection, vulnerable, and but also the patient is taking psychiatric medications. So how do we prevent the antibiotics that we prescribe from interacting with the patient's mental health and their psychiatric medications? Because that's the importance of knowing drug-to-drug interactions. Because a simple course of medicine can actually trigger an unexpected neuropsychiatric effect. So today we're going to deep dive into when infection meets the mind and how to be able to recognize certain things like drug to drug interactions, psychosis, things that we would like to protect the brain from any unintended consequences. We're going to talk about the latest research and we're going to go into this fascinating journey at the crossroads of infection, psychiatry, and diabetic care. So let's just say you have a patient, you're treating a diabetic foot ulcer, the wound is improving, antibiotics are working, but then suddenly your patient becomes paranoid, agitated, and confused. They refuse dressing changes and they think you're trying to harm them. Now, the question is no longer how do I heal this wound? The question is now, do I treat the wound when the mind is fighting the treatment? And you have to figure out what's going on. Like you need internal medicine to be on board. Usually, in this case, hopefully the patient will be admitted because it seems like something else is going on, right? So let's try to deep dive and understand that. I mean, to be honest, some patients get delirium just being in the hospital alone, just because of being admitted into the hospital. It's happened. It happened to one of my family relatives, and I didn't even know that. I didn't know that that was feasible. And when they got discharged out of the hospital, they returned back to normal. So it's very interesting to see how strong and powerful the mind is. So let's try to understand psychosis. Psychosis is not just a psychiatric diagnosis. It can be triggered, it can be worsened, and it can also be mimicked by other medical conditions. So key features of psychosis is delusions like paranoia or persecutions, hallucinations, disorganized thinking, agitation, or withdrawal. And in diabetic patients, psychosis may be caused by possible severe infection because that can happen. There's something called sepsis associated encephalopathy, metabolic derangements like the glucose swings and uremia, medication side effects, which we all need to know and be fully aware of, or pre existing disorders like schizophrenia or bipolar. So, how can antibiotics trigger a psychiatric symptom? So, some antibiotics cross the blood brain barrier and can cause confusion, hallucinations, agitation, and even acute psychosis. So, there are some high risk antibiotics classes that we need to be fully aware of, like the fluoroquinolones. We do like fluoroquinolones in a diabetic foot ulcer, like Cipro, right? But fluoroquinolones are primarily considered when it comes to diabetic foot infections where we're treating it for Pseudomonas aeruginosa. We already know that's one of my favorite bacteria, or gram-negative bacteria are suspected. So we usually use fluoroquinolones for that. But usually guided by culture results, right? So fluoroquinolones, they help treat gram-positive cocci like Staphylococcus aureus, but they are not first in line unless the culture shows that there's gram-negative involvement. So, like gram-negative pathogens like Pseudomonas aeruginosa, Enterobacteriaceae, fluoroquinolone sensitivity needs to be confirmed. And you also have to remember there are major side effects when it comes to fluoroquinolones, like levo or cipro, especially when it comes to long-term therapy. So when it comes to the psychiatric aspect of it, of fluoroquinolones like ciprofloxacin or levofloxacin, they're known for central nervous system stimulation, causing anxiety, causing insomnia, causing hallucination or paranoia. But other adverse side effects that patients watch out for, and primary care doctors and physicians and wound care specialists, is we all know about the clinical classic board answer tendon rupture, right? Tendinopathy. But you also have to think about fluoroquinolones cause QT prolongation. So you have to think about the heart. Cipro can also cause neuropathy, and patients have a risk of getting C. diff, okay, infection. And then you also have to think about renal dosing when it comes to diabetics, when it comes to chronic kidney disease. Next is the cephalosporins, okay, like cefepime. So cephalosporins are beta-lactam antibiotics, and we already know that they are divided into generations 1 through 4. Cefepime is a fourth generation cephalosporin that we use for moderate to severe diabetic foot infections, such as gram-negative Pseudomonas aeruginosus coverage is needed, especially in hospitalized patients. So cefepime is renally excreted. So you got to think about the patient's renal function. So, you know, especially if it is recommended by infectious disease, renal dosing adjustment is essential for patients who have acute kidney injury or chronic kidney disease. But cefepime can cause encephalopathy, can cause monoclonus, and can cause delirium that is mistaken as psychosis. So you have to keep that in mind and look out for those things, okay? And like I said, you got to adjust renal dosing wise to avoid neurotoxicity, okay? Next is the antibiotic metronidazole. Metronidazole is class of antibiotics that disrupt the bacterial DNA, which will result in the bacterial cell death because it doesn't have the DNA to replicate and move on, right? And it coverage is for anaerobic bacteria, so gram-negative and gram-positive anaerobic bacteria. So bacteroids, Clostridium, Pepto, Streptococcus bacteria, but metronidazole has no activity against aerobic ones that can survive in oxygen, gram-positive and gram-negative. It works better with it works only with anaerobic ones that survive can survive without oxygen, okay? So things like deep tissue infections or gangrene, abscess, osteomyelitis, a lot of times common combinations for antibiotics with diabetic foot infections when they add metronidazole and ciprofloxacin that will help cover anaerobes and gram-negative anaerobes, including Pseudomonas, or they might use metronidazole and cefepime, which will cover anaerobes or broad spectrum aerobes, okay? And you also have to think about the side effects of a GI upset, metallic taste, rare neurotoxicity, which will be something like seizures, and a disulfiram-like reaction when it comes to alcohol. But neurotoxicity is one of the things you gotta look out for, confusion or even mood changes when it comes to taking metronidazole. Next is Zyvox. Lin I always call this lizard one lizonide. Lizonide, but Zyvox, okay? I'm just gonna spell it out for you. Linezolid, okay? Zyvox. So Zyvox works by inhibiting bacterial protein synthesis by binding to the 5-OS ribosomal subunit. This subunit prevents the formation of the initiation complex of the bacteria. So Zyvox covers gram-positive bacteria only. So this includes MRSA, MSSA, Streptococcus species, Enterococcus species, including DRE, okay? But Zyvox has no gram-negative or anaerobic coverage. So when it comes to psychiatric side effects, possibly, right? Especially when patients are on psych drugs, so you got to look out for that if the patient's on any psychiatric medication. Serotonin syndrome. What is serotonin syndrome? It's actually quite life-threatening. It's a life-threatening condition caused by excess excess serotonin activity in the central nervous system because Zyvox is a weak, reversible MAO inhibitor. So it can increase serotonin levels. And this combined with another serotonergic drug, it can trigger serotonin toxicity. So drugs that could possibly increase serotonin toxicity are like antidepressants, or SNRIs or tricyclic antidepressants. Other ones like lithium, trazodone, other ones like opioids like tramadol, fentanyl. You got to think about all these things because if you add Zyvox to the patient's antibiotic regimen and they're on any of these, you add the risk of MAO inhibiting activity, which will increase the risk of having serotonin syndrome, which is life threatening. So, what is the classic triad of serotonin syndrome? Agitation, confusion, hallucinations, anxiety. The autonomic system is affected, so the patient might have hyperthermia, diaphoresis, tachycardia, and libel BP, blood pressure. And then neuromuscular wise can have tremors, can have clonus, especially along the lower limbs, can have hyperreflexia and rigidity. So the onset of serotonin syndrome is usually within hours to 2 days after starting the medication or increasing the serotonergic drug. So definitely look out for that. And how do you diagnose it? We just talked about the symptoms, but you also have to check if the patient has a history of taking any serotonergic drug use and their symptoms, okay? There's something called the Hunter's criteria that is commonly used for the diagnosis. They check for the clonus and other features, but there actually is no specific lab test. So labs mainly just rule out the other causes, okay? When it comes to possible patient having serotonin syndrome because they had Zyvox added to their treatment regimen because they had a really bad infection and they were on serotonergic drugs, you got to stop the Zyvox, okay? You need to get a psych on them on top of that. But you should be already be able to see just in the patient chart, should already talk to internal medicine and be able to know these things. That's why we as clinicians or healthcare providers and professionals, we need to know the list of all the medications that you're taking, every single one. Okay. So we can make sure there's no drug to drug interaction because antibiotics is one of the main things we do use to take care of a patient's diabetic, but also especially in infection. Okay. Other medications would be like benzodiazepines if the agitation is severe and tremors or seizures, okay? There's also a serotonin antagonist that they use in severe cases, but this needs to be treated by the healthcare professional. This is for education purposes only and for everybody to be more aware and treat people more thoroughly. Also, they're gonna have to monitor the patient's vital signs, the mental status, the kidney and liver function, and you have to watch out for complications when it comes to serotonin syndrome like rhabdomyolysis, seizures, or possible multi-organ failure. So it's actually very, like I said, very life-threatening. And so you stop the Zyvox, right? Let's say if the patient needed the Zyvox for MRSA or VRE, you have to consider alternatives like vancomycin or daptomycin if the patient is still high risk, okay? And like we said, we got to know the serotonergic drugs, and you have to have all the right people like psych on the patient, okay? And infectious disease, because ask them what is the better alternative for this, okay? So, antibiotic plus psychiatric medications interactions, okay? So, this is where it gets dangerous, but we have to know so that we don't risk people's lives. So, like we said, linezolid, Zyvox, aka Zyvox, plus SRRIs, high risk of serotonin syndrome. Okay, risk, know that. Fluoroquinolones plus antipsychotic drugs, patients are at risk of QT prolongation, and that can cause arrhythmias. And then antibiotics, you have to remember a lot of antibiotics do alter the liver enzymes, so toxic levels of psychiatric medications. So common psych meds, they like haloperidol or risperidone. Okay? So, yes, this is a challenge when it comes to diabetic foot ulcers, but what can go wrong? The patient can refuse the care, the patient pulls off the dressing, the patient misses the antibiotics, the patient walks on the foot despite being given strict offloading instructions. The patient doesn't trust the provider. Things can come about that, but the whole point is to help the patient's quality care of life, know your drug to drug interactions, make sure they help their mental status, okay? Make sure you have the right people on board, right department like psych, internal medicine, endocrinology, infectious disease, okay? But the clinical reality is also, you have to remember some people can get psychosis from infection, okay? Psychosis plus infection is kind of like a bi-directional loop. So infection causes inflammation, that causes the increase in cytokines, and that will cause brain dysfunction. Brain dysfunction causes poor compliance and worsening of infection. So this is especially dangerous in people who have neuropathy because they have reduced pain awareness. It's usually pain that gives us the first indicator, right? That something is wrong, that there's an infection brewing. They have that mask when they have neuropathy. Peripheral arterial disease, poor healing, and immunocompromised states. That comes a lot with diabetes. So, how to manage a patient when it comes to real strategy? Root out medical cause first, okay? Before labeling a patient as psychiatric, okay? Before saying, oh, that patient, check the patient's glucose. Make sure the patient's glucose, got to think about it. Could they possibly be hypoglycemic? Could they possibly be hyperglycemic? You got to check the patient's renal function. You got to look out for sepsis. You got to review all the medications because many psychotic patients are actually just delirious, okay? Which is, it's just delirium. And it's not just delirium, but there's a difference between the two, actual clear difference between delirium and psychosis, okay? The patient definitely antibiotics will need to be adjusted if it is one of the triggers for any psychiatric or psychotic symptoms for the patient having. So avoid any like central nervous system penetrating drugs if possible, okay? And then you have to remember that the patient's mind stabilization is also very important. And then you also have to always monitor the QT interval because remember, Cipro can affect that. Sedation, they're most likely going to sedate the patient if they're very agitated, and the metabolic effects, forgive me. So, what is the biggest key when it comes to this? Communication, getting your patient to trust you, being a patient being fully honest. Remember, they said there's three people you shouldn't lie to: your lawyer, your doctor, and your priest, right? Yeah, so don't ever lie to your doctor. 3 people you shouldn't lie to: your lawyer, your doctor, and your priest. There you go. So don't ever be like, "Oh, you're wrong," or I don't think I've ever heard a doctor ever tell anybody, "Oh, you're crazy," or anything like that because you should never, like I always say, never downplay anybody's symptoms, okay? People know their body better than you do. 'Cause it's their body. They've been living in this body for so many years, so they know when something's wrong, okay? You gotta trust that the patient knows, and for a patient to be able to verbalize that they think something is wrong, that is actually a privilege of them trying to trust you and to help save their own life, okay? So, doctors and physicians and clinical healthcare providers, we should say things like, "I understand this feels real to you. I'm here to help you. I'm here to help heal your foot from my point of view because I'm the foot specialist or the wound care specialist. Let's do this together, you know?" But the whole thing is about building trust and not confrontation and to give the patient the best quality care of medical care possible, right? And us knowing our stuff, not just like piling on antibiotics and watching them mentally deteriorate and not thinking, oh, could it possibly be a drug interaction and not even looking at the patient's chart or anything like that, okay? And definitely we'll most likely have to consider higher level of care, especially if the patient's feeling unsafe, the patient non-compliance is worsening, and there's also worsening of the wound, okay? So most of the time, patients will have to be admitted for IV antibiotics and psychiatric stabilization and controlled wound care. When it comes to that, the best thing to do is to simplify the wound care as much as possible, unless it's like something causing them to be septic where you have to take them to the OR, okay? Because complex regimens do cause a lot of agitation, but the whole thing is to heal the wound, stabilize the wound, and get the patient better. So, what are some red flags that you shouldn't ignore? That's why constantly one of the biggest red flags you shouldn't ignore when it comes to patients, a sudden personality change. How do you know that it's a personality change if you don't know the patient like that? You wouldn't. I'll never forget this one time. I am fully aware I like to know my patients. I like to get to know them. And I do believe people get to know them, especially when you're doing rounds. The patient, one day, it was like the day before their surgery, they were admitted and they were acting very, very off. The man was very calm and cool and able to hold a conversation. And then the day before, he just was not verbal, wasn't talking, staring out. I thought it was very odd. And it's a big difference from what he was doing the previous 2 to 3 days. Like, he was able to hold conversation, watching TV, just being normal, you know? And I noticed that sudden personality change, and I made it aware to my attending and everything, and they told internal medicine that, "You're a resident, so they don't really take you that seriously." Well, they didn't take me that seriously, but it did end up being something that I think the patient ended up having a I think he ended up having a stroke, but it was the sudden personality change that stood out for me. But it was only because I knew the patient, because they thought nothing was wrong, because they didn't know the patient. And wound care, it's really hard not to know your patient when it comes to wound care and patient having a diabetic foot ulcer, because it's such an intimate thing. You have to touch the patient. You have to heal their wound. You have to check for undermining. You have to check if it probes the bone. It's a hands-on job. So it's really hard not to know your patient. It's really hard not to try to make your patient feel comfortable. You have to make your patient feel comfortable and feel that they can trust you in order to change your wound dressing often, for them to have a gaping wound in their foot and to trust you with their care. It takes a lot. So, that takes a lot of courage. Another red flag, like I said, number one red flag is sudden personality change. Another red flag is new hallucinations after antibiotics have been started. Another red flag, refusal of life-saving care. That's a big red flag. Rapid wound deterioration and signs of sepsis. Deep insight that infection or psychiatry is not just about those two, okay? It's about the systems colliding. So your immune system, your nervous system, your vascular system, your behavioral system. And in diabetes, all of these are compromised. And that's why I keep on saying multidisciplinary approach. Vascular is one of the most important. Never ever forget that, okay? And I hope this episode was super helpful for everybody, because a diabetic foot ulcer doesn't just test your surgical skills. I keep on telling people it's a vast universe when it comes to diabetic wound and wound care. It actually tests your ability to think systemically, recognize medication effects, and manage human behavior under stress, because it is very stressful when it comes to diabetic foot ulcers or any wound and chronic ulcer care. Okay. So, because sometimes the bigger barrier in healing the wound is not the bacteria, it's your brain under siege. So, that's good for us to know. And I hope everybody liked this episode of Diabetic Foot Files. Because imagine, let's say the person, the Joker, like Batman Joker, what happened if he got like a diabetic foot ulcer from, oh no, or a pressure wound, right? From being bedbound. We would have to deal with that. So it's good to know. We would have to know all the medications, because usually patients in psychiatric wards, they are on psychiatric medications, and we have to know the drug to drug interactions, got to do cultures, all that stuff. But like I said, I hope everybody enjoyed this episode of Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.